Hello, everyone, and welcome to the latest session in CADIT's COVID-19 webinar series. I'm Chris Camel, Director of Health Technology Assessment and Rapid Response at CADIT. I'm speaking to you today from Ottawa, Ontario, Canada, which is on the traditional unceded territory of the Algonquin and Anishinaabe people. I thank all the generations of people who have taken care of this land over the years, and I encourage everyone who is participating today to think about where they are and to give thanks to the people who've been stewards of that land. This week is Digital Health Week, a time to recognize and explore how digital health is transforming the delivery of healthcare. Almost overnight, virtual care moved from an interesting idea to an absolute necessity fueled by the pandemic. The sudden shift has left everyone, patients, providers, policymakers, regulators, public payers, and health technology assessment agencies like CADIT with unanswered questions about the long-term impact. Can we and should we try to sustain the sudden momentum? How can we best integrate virtual care into our existing healthcare infrastructure? Has this revolution increased patient and provider satisfaction? And what does the evidence tell us? To dig into some of these questions, we're thrilled to be joined by three Canadian experts who will share their lessons learned before and during the pandemic and talk about the challenges ahead. Our format today is an informal fireside chat, so there are no PowerPoint slides. And while I can't help with the illusion with the virtual background of a roaring fire, if it helps, you can imagine that my guests and I are relaxing in armchairs near a stone fireplace on a cool evening, perhaps with a snifter of brandy or a hot chocolate or another drink that's appropriate for the time of day wherever you are. I'm going to introduce and talk to each one of our guests one at a time before I open the discussion up for everyone. You can send questions at any time during the presentation by clicking on the Q&A tab in the Zoom control bar. And please let me know who you direct your question to. If you have any technical issues, use the Q&A tab to let us know, and the Catalyst event team will try to resolve them for you. So I'm going to begin with Dr. Anne Collins. Dr. Collins is president of the Canadian Medical Association, and for 3 decades, she has had a full-time family practice in Fredericton, New Brunswick. In addition to her practice, she's provided care in hospital and nursing homes and was a residency teacher at Dalhousie University. Anne, before we dive into some of the policy issues, can you tell us about your own experiences with virtual care and then touch on the impact this overnight switch to virtual visits has had on doctors in terms of their day-to-day practice?
Thank you very much, Chris, and thank you to everyone for coming to this webinar. I will just first mention that I am coming to you from the unceded territory of the Wolastoqey people, the Maliseet people here in Fredericton, New Brunswick. So I will give you what happened in my practice in March. Following a 2-week quarantine, having been out of the country when the pandemic was declared, I was very quickly confronted with how am I going to how am I going to access my patients? And to put some context around what the pandemic meant to the grassroots physician in a community practice, I had a solo practice, was that the many public health protocols that were put in place and that were advised to us by our provincial public health authorities meant that we could no longer see people in our offices in any way near the way that we had prior to the pandemic. And furthermore, many of us, like myself, could not source personal protective equipment in our community practices. We buy our supplies from private companies, and none of those companies had what was required for us to practice safely in a pandemic environment, nor could we source, in my particular area, agents to clean our offices, which now needed to be done thoroughly after each patient visit. So that immediately sent us to an all virtual care model. And in my case, and in many cases, not just in my community, but across the country, that meant the telephone. And so that was a very challenging change in that it meant that we had to, there were certain visits that could not for a period of time take place at all. For example, prenatal visits. We could speak to the woman on the telephone, but clearly not do the examination part of that visit. I immunized the kids in my practice myself, so that was eliminated as they could not be seen in office. So it went to seeing, in my case, 30 to 35 people face to face a day in a fee-for-service practice, to speaking to somewhere in the area of 20 to 25 people through the course of the day over the telephone. So how was that helpful? Well, first of all, it was reassuring to the patients that they could still have some access. It allowed for follow-up of chronic conditions. It allowed for me and the patient to review investigations that they would have had done prior to the shutdown caused by that first wave of the pandemic, because of course that eliminated any routine lab work or x-rays for a period of time. It allowed us to review progress after having started perhaps a new medication. And probably the overarching thing was to address mental health concerns, anxiety around the pandemic itself, counseling people on whether their symptoms sounded like they might have COVID, addressing their concerns in that way, and directing them to public health should that be needed. So that represented a huge shift in the way that I practiced, and that the patients were served in our relationship. How did patients respond? On the whole, there were very few phone calls that I made that I didn't hear, "Thank you for doing this. Thank you for taking the time. I really appreciate this." Um, from my perspective, it was gratifying to be able to keep contact with the patient, but as someone who'd practiced for almost 34 years in a face-to-face model, it was a huge adjustment to not be able to see the patient, to be able to, when appropriate, just to lay a hand on as comfort, and then to decide, who do I need to see? How do I make arrangements for this person to be seen? Because there are still elements of medicine where the hand there needs to be a hand laid on the body for examination purposes, and as I said earlier, for those routine screening and routine visit purposes. So on the whole, a huge shift. As PPE became available, I did institute face-to-face visits, and at the end of my practice, as I finished that practice to take on this job, I was doing pretty much half and half, seeing patients in the morning and on a much lower volume, and then doing virtual care by phone in the afternoon. So Chris, that's an overview on that. I think in terms of the impact that it's had on physicians, it's been a huge change, and I speak primarily from the family doctor point of view. It's allowed flexibility for people to conduct their practices virtually from other locations, such as their homes, which has allowed them to do, perhaps in some instances, more contact in evenings, and so on. It has presented a challenge in terms of who to see virtually and who to see face to face, and then to develop ways to do that beyond the telephone, which is happening now, of course. So I'll leave it at that for now, and look forward to hearing from everybody else.
Thanks very much, Anne. So maybe by way of follow-up, you mentioned that at least initially, most of your work was done by telephone, and we do have other options like video conferencing now that are more readily in use. Can you maybe talk about how much that that lack of face-to-face contact that is bridged by the video option compared to telephone alone?
Oh, I think that would be huge. And I said, had I not known that I had an endpoint, the end of July was my endpoint, I would have very much ramped up and looked at platforms in order to provide good quality face-to-face interaction, just for the human contact, the eye-to-eye contact, but also it helps with the diagnosis of certain conditions. Family doctors see and are asked about tons of rashes, um, and even in some cases, lumps and bumps, other things that you need to see. Um, you need to see in order to make or to work towards the diagnosis. So I think that should be a critical component of virtual care, that you have that the eye-to-eye contact.
Great, thank you for that. Let's turn now to Mari Teitelbaum, Vice President of Strategy, Quality and Family Partnership and Chief Innovation Officer with the Children's Hospital of Eastern Ontario, or CHEO, as we call it here in Ottawa. As it turns out, CHEO had a 3-year plan to introduce virtual care in the hospital, but that was considered quite ambitious. But thanks to COVID, it was launched in 4 days from beginning to end. Mari, can you tell us how CHEO flipped that switch? What does providing virtual care in an acute care children's hospital during a pandemic look like?
So much, Chris, and I'd love to. There's nothing I like talking about more, actually. So like Anne, I returned to Canada from overseas right at the beginning of the pandemic, was locked away in a room, safe away from my family, as we brought virtual care online at CHEO at a scale we had never done before. Our journey started way back when we implemented Epic. Sort of 2012 was when we were really getting serious about it. And with funding from Canada Health Info, we were doing evaluations every step of the way. And so we knew technology could make a difference. We knew that 97% of our patients didn't notice a change in the interaction with their providers as technology was introduced. So we felt like we were on a good path. That also applied to virtual care. We had early adopter clinics who were doing video visits early on through Zoom, and evaluating that work to good success. But that was 1 or 2 clinics here or there, video visits, and also two-way messaging. So text messaging, email being done securely, things like that, to allow for offline communications. So grateful that we had done that, because we had the PIAs, we had the privacy impact assessments, we knew security was where it needed to be, and we knew what tools would work. And so incredibly grateful when March rolled around and suddenly it wasn't 1 or 2 clinics that wanted to use this functionality, it was the entire organization. And fortunately, we were able to flick the switch because we already had it in-house, with most of the work, that heavy lifting that generally happens before this type of thing had already been done. So very grateful for that. But obviously never consistent, right? We had some clinics that were quite happy to continue with the phone calls that Dr. Collins was describing and decided to go that way. And we had others who jumped right to the video visits. And in fact, one of my favorite stories is our mental health team, who managed to see 97% of the patients they'd been seeing prior to the pandemic, all being done virtually. And we all know that mental health through this time, and particularly in children and youth, is incredibly important. And so being able to maintain those relationships and maintain that care was huge. So that's the virtual care we all expected and had to turn on really quickly. But there's a couple of other stories or examples that I think really show the power of virtual care. So the first one I'm going to touch on is our virtual emergency department. So we actually had a project prior to the pandemic saying, 30 to 50% of our patients don't actually need emergency room services. How can we encourage them to find appropriate care in other places? And that was our project. Except when the pandemic hit, we found ourselves in the exact opposite situation. We had 10% of our patients showing up at the emergency department. And so you can imagine there was a lot of worry of those sort of 40 to 50% who were not presenting and who were trying to stay safe at home, but were then being missed. And so our emergency department physician said, well, can we just use the same platform we're using for virtual visits for a virtual emergency department? And so got that up, another example of getting it up in about a week with sort of questions in advance that patients would go through to ensure that a virtual visit was appropriate. You know, a limited form of triaging, and then being able to offer those appointments. The data around that has been amazing. So we've seen almost 3,000 patients in our virtual ED so far. 15% of those who complete a visit do require to come to the hospital. So it seems like a pretty appropriate ratio, and that other 85% can stay safely at home. And of all the visits, about 1% end up moving on to an admission. So pretty good confidence that we are reaching the right patients and ensuring that our virtual ED is having the impact we expect. The third example is virtual rounding. So again, as Dr. Collins mentioned, PPE was an issue, and keeping people who didn't need to be in the hospital, not in the hospital, was also incredibly important. And so you can imagine PPE and physical distancing when you have all sorts of people trying to gather for rounds was proving really, really difficult. And so the team got together and developed a virtual rounding strategy. And the benefits from that have gone way beyond what we had anticipated. So yes, you're saving the PPE. And yes, you don't have to exclude anybody, but you can imagine the family feedback on being able to join rounds remotely. So suddenly it's not just one family member that's joining rounds, but if you want others involved, you can actually extend the invite to them. We've been doing the evaluation on that. 72% of staff are very satisfied. 90% of staff have a good understanding of the care plan. And 80% of caregivers were satisfied or really satisfied with the virtual rounding strategy. One of my favorite examples, we collected all sorts of feedback from families, but they actually called it less intimidating and less overwhelming than, you know, all these people coming into a room and talking at you. The virtual platform actually leveled the playing field for them. And they loved it because Chio is 40 years old at this point, 45 years old. We have a lot of shared rooms. And so rounding would happen with the patient in the bed next door listening to all of it. And in this model, it is much more private and appropriate way of delivering care. So that to me was one of our favorite examples of virtual care, not only in the traditional sense, having an impact during COVID. I guess I'll just close with, I did have the opportunity to go to our family advisory committee last week to check in on how is virtual care going and is it working for you? And the positive response was a little bit overwhelming. We knew it was important, and we have heard from people that they're very grateful for the reach out. But they were just talking about the stress reduction in not having to leave their house, not have to travel on public transit, not have to pay for parking. All of that just brought the pressure down on the appointments in COVID or non-COVID times. They all felt confident that they would be seen in person if that was really required. So they felt like the decision-making was appropriate. And there's been a lot of care we've been able to provide that I think would otherwise have been canceled, because we are still seeing people cancel surgeries and the like because they're not comfortable coming into the hospital. And so we've been able to mitigate that with virtual care. So overall, we've still got work to do. We first saw our virtual care numbers peak at over 90%. They've dropped down to about 33% in that ambulatory environment. As things open up, people are very keen to lay hands on and make sure that the appropriate care is being provided. But as an organization, we are looking at how to set a target of around 50%. Obviously, it's not going to be the same in every clinic, but as an organization, we're expecting the target will land right around 50% to ensure we take advantage of what we've learned over the last number of months. And there is hardening to do. With whether it's figuring out the funding for the long term, figuring out the technology for the long term. Our patient said, if I go to ortho, I'm getting my invite one way. And if I'm in another clinic, I'm getting the invite differently. And so making sure that the experience for both providers and patients is consistent, still lots of work to do there. But overall, I would say the satisfaction rate has been high, in line with what the literature is telling us as we learn from all of this.
It does sound like a wonderful success story that you have at CHIO. I guess I'm wondering a little bit, like, what do you see as the biggest challenges to sustaining that kind of success? You mentioned a little bit about the
Yeah.
decrease in usage.
Yeah, so there's a couple of challenges. I think we're all learning. Zoom, Teams, whatever platform it's tiring, it's exhausting. A day on Zoom is not a day in person. And I think a lot of us are learning that firsthand. I don't quite understand it yet, but it is very real. And so finding a model, again, like Dr. Collins was mentioning, maybe it's a half day in person and a half day online to break it up a bit is going to be really important. And the funding is incredibly important. This won't work if there aren't sustainable remuneration models. At CHIO, we're on an AFP, but it's still a challenge making sure that the appropriate care is being provided in the appropriate way without funds on either side, be it government dollars or what providers are receiving go way out of whack, because I know there's a lot of worry about that. So we've got to figure that one out, but a great time to experiment and learn to inform that.
Thank you very much. Our third and final guest today is Dr. Robert Halpani, Chair of the Medical Services Commission in British Columbia. Robert, you've had a wide range of responsibilities during your career. You set up a medical practice in Vancouver. You were the CEO of the Interior Health Authority. You've even been a member of the CADA Board of Directors. So my opening question for you is, what is your experience with virtual care and what are some of the lessons that you've learned?
Well, thank you for inviting me. I'm coming to you from Kelowna and on the unceded territory of the Syilx people. BC has had a long history of telehealth, and that's our original term for virtual care. Programs include telestroke, telerenal, telepsychiatry, telethoracic, just to name a few. Of note, the telethoracic program in Kelowna serves patients from as far away as the Yukon, and it saved patients and the environment over 16 million kilometers in travel over 17 years. The Medical Services Commission determines what is and what isn't a benefit for residents of BC under the Medicare Protection Act, which incorporates the principles of the Canada Health Act. The Commission approves the fees paid to physicians on a fee-for-service basis. And about 2 years ago, the Commission noted an increase in the number of third-party virtual care providers in BC, probably facilitated by the fact that BC already had telehealth fee codes, which pay virtual care the same amount as face-to-face. We had and have a number of concerns about this episodic service. And some of these concerns include the lack of alignment with the provincial strategy for primary care, which is based on the principles of longitudinal care and continuity of care. It does not conform with the principles of the College of Family Physicians of Canada, which state the family physician is a skilled clinician. Family medicine is a community-based discipline. The family physician is a resource to a defined practice population, and the patient-physician relationship is central to the role of family practice. So this episodic virtual care is also contrary to the benefits of a healing relationship in primary care. The Commission has concerns about clinicians providing services to BC residents from other provinces. These concerns include continuity of care, appropriate referrals, ordering of lab and DI tests, prescription renewals, and auditing their billings, which is another function of the Commission. And also there's a potential for and the perception of extra billing, which is charging patients for a benefit, such as an extra fee to be seen at certain times of the day. So as you all know, COVID's been the tipping point for the use of virtual care. In BC, when we compare paid claims from March to June of 2019 to the same period in 2020, general practice went from $348,000 to $4.3 million. Specialist payments went from $198,000 to $1.2 million in that 4-month period. So as Anne has mentioned, this shift has been facilitated by physician commitment to patient care, protection of patients and staff, lack of and cost of PPE, and last but not least is a stable revenue stream. So prior to COVID, the fee schedule for telehealth included only video technology. So in order to increase access for patients, the use of the telephone was included in the same fee code. So now when we go back and look at that shift of virtual care, we are unable to determine whether the actual use of video or telephone. So my assumption, and Anne kind of helps me with this is that there's been a dramatic increase of the use of the good old telephone, which is now a billable item with no additional technical costs and no learning curve. In BC, we had daily volume limits, and we still have daily volume limits for primary care. And physicians seeing between 51 and 65 patients are paid at 50% discount rate. So to increase COVID access, we eliminated the daily volume limits. And we saw a dramatic increase in the number of patients being seen in a day. In some cases, more than 95 patients a day were being seen. We've since reintroduced daily volume limits. And prior to the second wave, which I think we're now in, the commission was informed by the college of an increasing number of complaints related to virtual care. An example is a patient being informed of a cancer diagnosis, having never seen the physician, and being told the diagnosis over the phone. The college regulates the standard of care, but not the technology. I think it's important to remember that the standards for patient assessment and documentation are the same, whether the interaction is face-to-face or virtual. And failure to perform an adequate physical examination is one of the most common deficiencies identified when patients suffer adverse outcomes and bring complaints to the college. So going forward, post-pandemic, patients are going to demand a continuation of virtual care. And we'll need to address issues of quality management and compensation. As Maria has mentioned, those compensations, we're going to have to take into consideration both virtual care, email, and texting. But I think we have to remember that fee-for-service creates a perverse incentive for volume of services. And most important to me is providing the right service to the right patient by the right provider at the right time and at the right cost. In other words, not always a physician. It's important to find a balance between patient convenience and the appropriate use of virtual care. And this is a really touchy subject, but in a universal healthcare system, rationing is a fact of life. The economic term moral hazard means that by lowering the marginal cost of care to the individual, there may be an increase of healthcare use. And I do note that the evaluation of Babylon by the NHS in Britain showed that patients may be using the service more than would be expected given their age and health status, with higher consultation rates. Clinicians are a scarce resource, and their education, knowledge, and experience must be maximized. An ethical question for the group to think about is, should we be providing priority access to virtual care to populations who will benefit the most by a reduction in morbidity and mortality, such as mental health, chronic disease, cancer care, and our most vulnerable populations? My concern to that question is that we'll have 15 different answers or 13 different answers to that question. And importantly, we must guard against the marketization of patient data. Large companies such as Amazon and Microsoft are entering the healthcare field and gathering data from many sources. We need to know where the data is being stored, who has access to that data, and for what purpose. Hopefully, the upcoming changes to the Federal Privacy Act may address some of these concerns. Thank you.
Thank you very much, Robert. I'd like to just follow up on sort of the notion of unintended consequences. So this change happened very quickly, and there might have been things that were not anticipated, and I think you touched on some of those. I'm just hoping you can perhaps elaborate on what, if any, concerns you might have about unintended consequences with the widespread adoption of virtual care.
Yeah, I can think of two come to mind, and having been CEO of Interior Health and having rural and remote communities, recruitment and retention is a huge issue for these areas. And if those communities are paid fee for service, if virtual care takes away the target incomes from those individuals, they're going to leave, and recruitment will be a problem, and the community has a slow migration out. Certainly an answer may be putting people on alternate payments methodologies. And my second concern long-term is the scope of practice. And in BC, we have approximately 150 physicians who practice 95% of their practice as virtual care. And my contention is that they're not practicing to their full scope and run the risk of being replaced by an allied healthcare provider, following the premise of the right provider seeing the right patient for the right reason at the right cost. and they're going to have to re-engage, and it's going to require training.
Thanks very much. So we're going to broaden the discussion now, and everyone online is invited to submit questions for our guests using the Q&A tab in the control bar, and they're having questions rolling in. When you submit a question, again, please tell me if your question is intended for a particular person on our panel. And maybe I'll start with one that selfishly that Kadeth is interested in, and I'll pose this to all three of you because you've all talked about delivering care in an appropriate way to the appropriate patients. And so how are you each, or maybe not personally, but in your settings, making those decisions about who it is appropriate to provide virtual care to and who requires a face-to-face type of interaction? And maybe I'll start with you, Dr. Collins.
Thank you for that question, and it is an excellent question, and really at the crux of discerning who you see in person and who you don't or don't necessarily have to. There are certain medical situations, certain symptoms that require a physical examination, and so what CMA has done as a resource is commissioned both a physician playbook and a patient playbook, and outlining or suggesting, like for example, you do have to examine someone who has back pain or headaches. That has to happen at some point in time. So it's a reminder to physicians, and it's also a good trigger for patients as well. I have had it happen to a family member of mine who called and wanted to be seen about a back pain concern and was given a virtual appointment, which was not necessarily, in my view, appropriate. So those are two tools to help both physician and patient in deciding unfortunately deciding and pushing perhaps for which type of appointment is appropriate for them. So and then there are other things you can't do pap smear. Pap smears have to be done. Immunizations have to be given. There are certain parts of the anatomy that need to be examined that cannot be done virtually. So some of those you just can't get away from that, and so you have to make and most of the comments that we're getting are on primary care. But the same applies in some specialties as well. So yeah, that's what CMA has done as a tool to help both physicians and patients.
So Mari, maybe I'll turn to you with a similar question or the same question about how you identify appropriate patients, in particular in that emergency department setting, where I think our expectations are possibly incorrectly that most patients would need to be seen in a face-to-face way if they're presenting to an emergency department.
Sure. So very similar answer. We do have guidelines and for both our providers and patients in the ambulatory environment, as well as for our emergency department, to help people decide what's most appropriate, with sort of a blanket direction of, even if it says it should be virtual, but you feel it's really important to be seen in person, that's a clinical decision to be made between the provider and the patient. And so nothing is set in stone. These are all recommendations. In the ED, it's actually fairly straightforward. So, if you think you've broken an arm and are fairly certain the bone sticking out, our screening tool is quickly going to tell you, you just need to come in. We're not going to be able to help you from home. Earaches, fevers, rashes, there's an awful lot that presents to our emergency department that may not need to be seen. And so that survey off the top tries to triage to make sure the right people are taking the virtual route versus the inpatient route, and being seen where most appropriate. The story I really love actually is the examples of, we have an HA1C drive-through now. So we knew that those visits in our diabetes clinic, 90% of it could be virtual, but there was this one step that needed to be in person. Rather than making the entire clinic in person, they continued with the virtual visits, but a couple of evenings a week, you can come through our drive-through and have that one test done. The same for immunizations, things like that. So again, de-risking by, you don't have to come through the hospital, you're staying in your vehicle. but we can have a human connection where needed and the virtual connection where appropriate. So lots of ways to make sure that the right care is being provided in the right way.
And so, Dr. Halpani, again, along the lines of appropriateness, maybe you could talk a little bit about whether there are some sort of gray areas or gaps where it's not clear whether a patient in a certain condition would be appropriate for virtual care, and how, for example, an organization like CADITH, which specializes in evidence, might be able to help close some of those gaps.
I think the important part to remember here is not to set targets. And some places are suggesting that, a certain number of patients should be virtual care and others should be face-to-face. And Marie, you hit the nail on the head for me. It's clinical judgment that makes the determination. But I think that clinical judgment really should be based on the relationship that an individual has with a team or a practice and the access to information. So the worrisome thing for me is that individuals are making decisions without access to the primary care record, have no knowledge of the individual. And obviously we've seen cases where people are making referrals to a specialist because the specialist can do the physical examination. So I think from a CADITH perspective of where we're going from a research, we will need to go back and look at the appropriateness and ordering practices compared to a regular family practice of lab, DI, emergency use. Is there overutilization? Is there underutilization? Is there appropriate utilization? Big question, but we don't have the data yet.
Right.
Can I jump in on that?
Yes, of course.
So I would be curious about evaluating also actually the targets. So because I am curious what targets will do. We have been through a time of experimentation, but society has a habit of going back to its comfort zone. And so I think it would be interesting to study an environment where no targets are set versus where there is a specific effort to maybe change behaviors based on what we've learned. Because it is hard, I would argue it's almost harder to provide virtual care, but that doesn't necessarily mean we shouldn't be given what families and patients are telling us as it relates to what it means for them. Absolutely.
But I think the importance is having outcome measures. And one of the dilemmas that we face is we don't have standardized outcome measures. Even from one site to the next, everybody says they're using PROMs and PREMs, but they're all different. Mm-hmm. And so the standardization to be able to actually do the measurements and then do the comparison, I think as we go forward, I think it's really necessary that we have appropriate PROMs and PREMs as an example that are standardized across the country.
Yeah, we completely agree.
So I'd like to sort of shift direction a little bit to talk about access. And we have a question from Brian Jorgensen from the Saskatchewan Cancer Agency. And he's asking you, Mari, you talked about how you were able to incorporate virtual care with your mental health patients and teams. And he's asking whether you encountered significant technological barriers with this often marginalized patient population. And maybe I'll start with that.
Yeah, that actually, so always a worry. Absolutely, always a worry that we're not making things worse by providing care to those who have the infrastructure and the tools and not providing care to those who don't. That's not played out. So we had a program where we could get smartphones to people who maybe didn't have them to enable care that way. And we've been watching it all very closely, and it's not been a huge concern for that team. I don't have the tangible data in front of me, but I'd be happy to follow up. Overall, they were able to address the worry in most instances.
Thanks very much. So a question for you, Anne. As a medical doctor with previous practice experience, this is a question coming from Puye Grayley. I wonder how virtual visits are more exhausting than the face-to-face visits from your point of view. If the number of visits don't exceed the face-to-face visit, and we have certain standards to screen patients for this type of visit. So I think it's a question about, in what way are those virtual visits more exhausting than face-to-face? Like if the numbers of visits are roughly equivalent.
So it goes back to Mari's observation and my thoughts about the whole Zoom fatigue thing. I don't have a scientific answer to that question. I'm not sure that there is one. I'll give you my personal reflection on it. When you're seeing people in an in-person environment, you're having human contact, which I think we all feed off of, not always in a positive way. You know, we all have frustrating days and days when we're not at our best. The other thing, just a physical aspect of it, in my practice when I was operating fully on a in-person visit, I was up and down, in and out. You're moving all the time. When you're sitting in front of a screen, as we're all doing right now, or on the phone, often for obviously for privacy reasons and so on, with a closed door, that I think that loss of physical activity contributes to it wholly. So those are my very personal thoughts on that. If Murray and Robert have anything else to add, I'd be interested in hearing it too.
Robert or Murray, anything to add to that?
In the Zoom meetings that we've had over the last while, almost to a person, the clinicians say the exact same thing that you're saying, Anne. It's not that they're just tired at the end of the day, they're exhausted.
Yeah, it's real. We need to study that.
Thank you for that answer, all three of you. Robert, what do you think about a potential issue around double dipping, so to speak? So one person goes to see a physician virtually, and then they have to go to for an in-person consultation for the same issue. You know, this has the potential to increase healthcare costs. So how do we triage that type of encounter, and is there a way to address that sort of issue?
Well, we're already seeing that, and during COVID, we're probably a little bit lax on following up on that type of issue, because we would want to make sure the patient is seen. But I think some of this may go back to an appropriate triage before a patient actually sees the clinician. In BC, we have an 811 line where it would be more appropriate to make sure we direct patients to the right person at the right time, and then the determination about whether some type of physical examination is needed. And the issue now is that because a number of physicians are practicing from their home, very often there's no one in their office. And so I think it's going to change how physicians practice, and I think it's going to drive toward larger practices using an office more efficiently and having patients available. But again, I really struggle with these one-off episodic cares that are not connected with some sort of team and provide a continuity of care. One of the ways we can maybe address those, which we're looking at, is obviously financial incentives and disincentives. Should we be paying the same amount to an episodic care that is not connected or not providing continuity of care? I think you know the answer to that.
So I have another question, which it's about the patient experience, but I think it also maybe applies to the physician experience. And maybe I'll start with you, Anne. So not all patients and potentially not all physicians have comfort with virtual methods of communicating. So what type of training or support or education or upskilling might be required for those less comfortable with online connectivity?
Yeah, and so this is something that I can answer from both perspectives. So from CMA's point of view, we recognize that first of all, given that virtual care is here to stay, both from a patient acceptance and a physician acceptance point of view, that in enhancing digi knowledge or virtual care knowledge is something that does have to happen on a national scale, and that goes beyond just making sure that ensuring that there's good broadband access across the country, particularly in rural and remote areas, and from a physician-patient relationship point of view, it's really it's like any part of the relationship is having the discussion about are you comfortable with this? Can you manage this? And not everybody can. Not everybody has a smartphone. Although we have smartphones, we still have a landline that our grandkids look at with great amazement. But you need to have that conversation, and it needs to be tailored to the patient on the one-to-one basis. But from a national perspective, that needs to be looked at from the equity lens as well. What do we do to ensure that there is good and equitable and affordable access across the country? So still much work to be done in this area. We're really still in its infancy in terms of the widespread practice of virtual care.
So a question maybe for all three of you, it's related to the shift that virtual care has brought. So now, patients maybe have a bit more experience with the convenience of accessing the healthcare system from their homes. Do you see more mobilization of other areas of healthcare? So for example, mobile labs and services coming to the home, sort of a return more to a house call type of model, potentially? Maybe I'll start with you, Robert.
Well, as someone who used to make house calls and knew the benefit, I think the modality doesn't necessarily drive how a patient's seen. It's the clinical presentation. And, as we go forward, you talk about mobile labs, et cetera, we're going to have to pay attention to what's going to be available on this little thing. There's Amazon has a cardia.ca, and you can go on and get your ECG done. I anticipate that they're going to be able to get your oxygen saturation and the number of tests that are going to be able to be available on this device that must integrate with the information in the clinician's office. And clinicians have to be trained and have core competencies in how to integrate. So we've got a lot of work to do, but staying ahead of the curve is the hard part.
Anne or Mari, do you have anything else you'd like to add to sort of the concept of house calls or more mobile health care? Mari?
I'll jump on the house call piece, because that's one of my surprises in all of this, is the number of providers who comment that a video visit is sort of like going back to the house call, and that you can see the environment they're in, who's around them, and sort of what life looks like outside of an office. And so I did find that a fascinating observation about the introduction of virtual care, not telephone obviously, but the video visits. To your original question, a friend of mine, Dr. Kuman and Wilson, wrote a great article around the concept that, how do I want to say this? So streaming music as is to vinyl, as virtual care is to in-person visits. And so essentially, yes, when you want the depth and study and human interaction of and need that in a face-to-face visit, that has its benefits and its place, just like listening to music on vinyl is a very is an amazing experience and brings that depth with it. But in the same way, a lot of us are listening to music over different streaming platforms because there is a convenience and a simplicity to it that gets you the basic information you're looking for no matter where you are. And so I agree with Dr. Halpani that as the tools make those additional bits of information more easier, I do think that we are going to see more and more of care in different modalities happening, as it's happening everywhere else in our lives. This is not new. We're behind the curve. We're not ahead of it.
And Chris, if I could just add one comment around, Robert mentioned core competencies. Just prior to the pandemic, the CMA released a virtual care task force report, which it did in conjunction with the Royal College of Physicians and Surgeons, as well as Canadian College of Family Physicians. And there were 4 working groups within that task force, and one of them was around education. And I saw in one of the questions a question about residents. That's where the competency, why that triggered this, you know, how are residents being trained? And that was certainly a concern that we saw during the first wave of the pandemic, in that what happened with those residents who were in physicians' practices. And right now, the AFMC, the Associated Faculties of Medicine, are looking at ways to integrate virtual care in a greater fashion into residency training, into the training of the future physicians, because that's clearly got to be a part of this as we move forward.
Thank you. A question for you, Mari, and it's, I guess, a fairly specific one. Can you please explain the process at CHEO to obtain informed consent from patients or parents for video conferencing?
Yeah, that's a big one. And so it changes, right, over time. So when we first stood things up, we were using what we'd learned in the pilot project. And I just heard this morning in a meeting that the consent has evolved based on what we've learned. And so I'm gonna tell you what I know, and I may come back to you with a correction later, but essentially it is verbal informed consent that is then charted as part of the visit. And it does happen with each and every interaction at this point. There is no blanket consent to ensure that, again, that visit is in a safe environment where the purpose of the visit can be met and everyone is understanding of what's about to take place. So it is definitely a key part of all of this, and it's not straightforward yet, but we're working on it.
Question for Dr. Halpani. In your opinion, how could we balance the need to ensure appropriate care is provided with not discouraging or disincentivizing the provision of virtual care where it is appropriate, especially in a fee-for-service environment?
Well, I think part of the dilemma there is the fee-for-service environment in primary care. And I, unfortunately, am of the position that alternate payment models for primary care promote the right person seeing the right patient at the right time. And clinicians, again, physicians have the knowledge, experience, and we have to make sure that that's being used on a consistent basis. Seeing the things that could be seen by someone else and charging fee for service does not make sense to me. So I guess the change in payment methodology over time is a goal that I would look for in primary care.
And so a question for you, and not related to the fee-for-service model, but have you ever done virtual care with a new patient that you've never seen before in person? And if so, was it different? If virtual care is here to stay, which I think we expect it is, like how would that change practice generally?
Personally, no, I have not. I had a 30-year-old practice, and so you don't see new patients very, very often. I'm not so sure that for that initial visit, if done particularly with a video platform, and that, in my view, is a clear way to go. I am not so sure that that would change that interaction considerably. In a non-acute setting where you're having in most instances now, what I see in my community, and I suspect it's not unique to here, is that it's done from a primary care point of view as a meet and greet, and so the questions, the interaction, they're generally, unless there is an acute situation, would not involve an examination. So from that perspective, I don't think it would change it too much. I know that I've talked a lot about primary care, but I know that there have been many patients seen on referral by specialists in various fields that would involve a video visit, and that would be a new patient to that physician, to that clinician. I can tell my reflection on that for getting some of those letters from those consultants. I was quite taken with how accurate in what I knew about the patient and how they reflected that through their meeting and so on. It was quite accurate. And then, of course, follow-up was made in whatever way needed for an in-person visit later on. So I don't think it would change it incredibly for that kind of preliminary interaction.
Thanks very much. So unfortunately, we are almost out of time, and so we do have to bring the discussion to an end, which is unfortunate because there is still a wealth of questions for each of you, and it's been a very rich and wide-ranging discussion. Before we go, I would like to give each of you the opportunity for a final word, and maybe we'll go in the reverse order from where we started. So Robert, in less than a minute, can you give policymakers and Canadian health ministries one piece of advice on successfully integrating virtual care into the current system? What do you tell them?
Well, the fact that it's Digital Healthcare Week, I think that we have to recognize that virtual care is just one component of the digitization of healthcare, and the importance of the movement of information from one provider to the next, and including the patient in that movement of information, I think is of prime importance. So my request is, as we digitize, let's make sure that we prioritize and implement those components that are going to have the biggest impact first, and also provide the foundation for moving forward. An example would be e-referrals. We're still using the fax in Canada, and it's the biggest privacy breach that we have. So it's the whole picture rather than just looking at virtual care.
Mara, you've been integral to overseeing a massive change management exercise in an acute care hospital. What is your best advice on preparing for the sustained use of virtual care over the long term?
Yeah, so I feel a bit like we're at the Model T level of virtual care. So this really is an experimental time, and we have the opportunity to study things in a way we might never have had. There is a lot to do, and we do need to study it, and we need to be thoughtful about where we invest, but we just can't go back. And so we need to work hard at making sure we prioritize the right things, but that we don't go back to our old ways, and that we continue to move on from the Model T to the Tesla in short order than that.
And finally, Anne, just to wrap us up, the pandemic has highlighted the importance of intense collaboration across the health system. So what is your takeaway on how we maintain this collaboration and patient partnership going forward?
I think that we have to always keep the patient as the center of our focus, but in a partnership way with that individual sitting with you at the time. And I think that we need to see collaboration on a national or a federal level in helping to with stakeholders. We need to help educate and provide the patient what they need to feel well taken care of and to be well functioning in this digital and virtual care world.
So that brings us to the end of today's session. A big thank you to our three experts and to everyone who tuned in today and contributed such great questions. I really feel like we probably could have gone another 2 hours going through questions and having a very rich discussion about the impacts of virtual care and how to manage that type of change going forward. A short evaluation survey will open in a new window when you exit the webinar, so please take a moment to fill that out. And the webinar will be posted to CADIT's YouTube page later this week. I hope you can join us for the next COVID-19 webinar on December 3rd. The topic for that webinar is community-based aerosol transmission of COVID-19 and HVAC systems. And don't forget that all the sessions from the virtual CADIT Symposium are now available on demand, along with new pre-recorded content. So until next time, continue to wash your hands, wear a mask, and please stay safe. Thank you, everyone.